Hey, it's Jess. So 6 quick slides about meningitis. Itis of the meninges, inflammation of the tissues that are surrounding the brain there. So I'm going to share my screen. And this is found in acute intracranial problems, pages 1338 to 1341. So meningitis is, like I said, inflammation of the meninges. There are membranes that protect the brain and the spinal cord, and those are the meninges. So what happens is there's a big inflammation reaction, and there's a formation of exudate. Exudate's otherwise known as pus. And that exudate, the pus, clogs up, makes the cerebral spinal fluid sticky, gummy, clogs it up, and increases the intracranial pressure. And I've talked about intracranial pressure. Oh, nope, I haven't talked about intracranial pressure before. I don't think. That was a different life. So intracranial pressure is your brain is in a little box, and it can only take so much pressure. Too much is way too much, and not enough is not nearly enough. It's a very, very tight range. So when we have those clogs of the cerebral spinal fluid, and we have buildup of the cerebral spinal fluid, and we have increased intracranial pressure, we have big problems. So in addition to the big problems, we'll have congestion and edema of that surrounding tissue too. So like everything from the skull in is angry, it's inflamed, and it's creating problems. The most common cause of meningitis is viruses. And viral meningitis will resolve without treatment. However, if you end up with bacterial meningitis, which is why a lot of people end up getting a meningitis vaccine, the meningococcal vaccine, it's highly contagious. It has a really high mortality rate. And so we have vaccinations for high-risk people. High-risk people include infants and college students living in dorms. Legit, in the 90s, there was a huge meningitis outbreak at Mankato State. And so I'm at Moorhead State and during this time and living in the dorms, and my mom is freaking out. So what happens when people, this is what we need to be aware of. Excruciating headache, that inflammation and the increase in intracranial pressure creates the worst headache they've ever had, like the worst. Like migraines, nothing, like drop in the bucket compared to the excruciating headache that's associated with meningitis. You will also have this thing called nuchal rigidity, which means that if you lift up the neck, then there's reactions in the legs. Look it up on the YouTube, it's kind of cool. Lights hurt. They'll be a very high fever. They'll have chills. They'll have altered LOCs. They'll be tachycardic. They'll have nausea, vomiting. They'll seizures. Like that's how high the temp gets, is to create seizures. They may have a red rash. They'll be restless and they'll be irritable. The reason I say they may be having a red rash is because I got exposed to bacterial meningitis one time and there was no rash. But I got to get some prophylactic antibiotics for it. Yay, nursing. So diagnostics surrounding meningitis include having a lumbar puncture and cerebral spinal fluid, like when we were talking about the pituitary surgery and the sphenectomy that we were using to be able to work with the pituitary gland, that CSF is clear, except for if you have meningitis, because the CSF travels right along the meninges, and so it gets cloudy. That cloudiness is the presence of WBCs, and then elevated protein and glucose levels. So what they'll do is they'll smear and culture that CSF, and then depending upon the amount of pressure, like you should have some pressure coming out from your CSF, but if it's like when you do your lumbar puncture, but it could be like squirting out, and that can indicate the amount of blockage and pus when you're actually doing the spinal tap. A lumbar puncture is otherwise known as a spinal tap. So nursing care, isolation, 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 droplet precautions, up to 24 hours after starting antibiotics. This person the person that exposed me had not received antibiotics, was septic. I happened to be really good about getting the blood pressure. I got a systolic of 50. I got nothing diastolically, but I was in there without a mask, and I ended up getting some prophylactic antibiotics. That's the only thing that happened, but I ended up with prophylactic antibiotics because of that. We are going to be doing fever management and trying to keep them afebrile and creating a healing environment. That's maybe that we're using some therapeutic cooling. We'll work with them on pain management. We'll be doing vital signs and neuro checks quite frequently to make sure that they're not going septic. And then we'll be encouraging them to be on bed rest, because moving out of the bed can increase the intracranial pressure. We'll also keep that head of the bed at, let me position my hand the right way, 30 degrees, because flat creates a lot of intracranial pressure, because that means gravity is not our friend at all. If we can raise that head of the bed 30 degrees, gravity is our friend and releases some of that intracranial pressure and then puts it down in the lumbar, puts some of that CSF down in the lumbar area, rather than having it be up in the old cranial skull area. Medications for people who are having problems with meningitis include Rocephin or chloroform, or in combination with vancomycin. We're going to be giving them the broadest, most broad spectrum antibiotics that we can. If for whatever reason the increased intracranial pressure and fever are causing seizures, we can start them on some Dilantin. We're also going to be starting them on corticosteroids, usually IV corticosteroids, to be able to help with the inflammation process that's going on with the meninges as well. Commonly used is Decadron. This little picture here is a picture of the dorm at Mankato State that had the problem with the meningitis outbreak. Easy for me to say. So roles in this particular situation. So RNs will be assessing, teaching, making referrals, and passing medications. LPNs can also pass medications, and they help to, this is probably one of the few times that I've actually talked about different roles and how things get delegated and nursing activities get delegated in healthcare. So let's get into it. I had talked about RNs already. So LPNs can pass medications. They assist with activities of daily living. They take vital signs, and then they alert the RN to abnormal patient data. And then our UAP, PCA, CNA. So, and when I was in North Dakota, I was a PCT. So this is they assist with, that's that level that you are, some of you are working at currently as UAPs or PCAs or CNAs. You're helping people with ADLs, you're taking vital signs, and then you are alerting people, the RN or the LPN, to abnormal patient data. Not necessarily generating interventions yourself, but definitely being on the lookout for things. In addition, we can have physical therapy assisting patients with mobility issues and providing access to assistive devices. OT, you'll commonly hear me talk about PTOT, physical therapy, occupational therapy. Physical therapy does the big stuff. They do the gross motor movements. Occupational therapy does the fine motor movements. So they're all about the ADLs, bathing, dressing, toiletries, or toileting, eating, providing assistive devices for ADLs as well. So making forks easier to grab, tools to help people put socks on, those sorts of things. Speech therapy helps people with talking, swallowing, and other methods of communication. Sometimes I think you may wonder whether I don't need a speech therapy consult myself. And then they provide access to techniques and resources to decrease risk of aspiration, and they order and assess swallow studies. So what they do is they make sure that this patient can swallow things and get it into their stomach rather than having it go into their lungs. Aspiration. And then social workers. So social workers assist patients and families with discharge issues. They get people to the next level of care. They help arrange transportation, and they help with financial concerns. So let's say for whatever reason, a person is in the acute care hospital and they need to go to the swing bed unit or to the nursing home to be able to continue on with their care. Then the social worker helps makes those arrangements. They also get people home. So I know that I had a lot of people, and I'm sure that happens to a lot of people here too, where they're from pretty long distance away. And unless they came here scheduled on purpose, like for instance, my cousin Paul needed to come to Mayo for some heart stuff. But the reason why he got here was because he came in Mayo 1 from Fairmont, because he came from Sherburne in an ambulance. If Paul couldn't get home, social work was going to be the people who were able to get him home. Just to explain some of the different abbreviations that you'll see here in the slideshow, NH, nursing home, HHC, home health care. So they provide some healthcare in the home, and it's normally set up on maybe the day of discharge or the following day. They kind of do safety evaluations as well. And then they determine what sort of services they can provide to the patient with them staying in any sort of other care facility. And then people can also be discharged home to self-care. So that's the family might be helping out, the spouse might be helping out, but there's not any additional services needed. So I'm going to stop sharing. That was meningitis. And I'm going to keep recording. I will see you in another one, or I will see you in class. Have a great day.